Hello everyone, welcome back. Today we'll discuss hypophosphatemia, an electrolyte disorder that is frequently overlooked but can become life-threatening, especially in critically ill patients. Phosphate is much more than a component of bone. It is essential for ATP production, cellular metabolism, oxygen delivery, muscle contraction, membrane integrity, and intracellular signaling. Patients with severe hypophosphatemia can develop respiratory failure, cardiac dysfunction, rhabdomyolysis, seizures, and hemolysis. In this video, we'll cover physiology, causes, clinical manifestations, diagnostic approach, treatment, and important ICU pearls. Let's begin. An average adult contains approximately 700 grams of phosphorus. Distribution: 85% in bone, 14% inside cells, and less than 1% in extracellular fluid. This explains why serum phosphate may not accurately reflect total body phosphate stores. Normal serum phosphate: 2.5 to 4.5 milligrams per dl or 0.8 to 1.45 millimoles per liter. Phosphate homeostasis is regulated mainly by vitamin D, increases intestinal absorption, parathyroid hormone, increases renal phosphate excretion, and fibroblast growth factor, 23, reduces phosphate reabsorption and suppresses vitamin D activation. The kidneys reabsorb nearly 80 to 90% of filtered phosphate in the proximal tubule through sodium phosphate cotransporters. Hypophosphatemia is classified as mild, 2 to 2.5 milligrams per dl, moderate, 1 to 2 milligrams per dl, and severe, less than 1 milligram per dl. Clinical symptoms usually become significant when phosphate falls below 1 milligram per deciliter, although critically ill patients may deteriorate even with moderately low levels. The causes can be remembered using 3 mechanisms. Number 1. Decreased intestinal absorption. Examples include malnutrition, chronic alcoholism, vitamin D deficiency, chronic diarrhea, antacid overuse containing aluminum or magnesium malabsorption syndromes. 2. Increased renal loss. Causes include hyperparathyroidism, Fanconi syndrome, renal tubular defects, acetazolamide, diuretics, post-kidney transplantation, and oncogenic osteomalacia due to excess FGF23. Number 3. Intracellular shift. This is particularly important in ICU patients. Common causes include refeeding syndrome. After prolonged starvation, carbohydrate administration stimulates insulin release, driving phosphate rapidly into cells. Treatment of diabetic ketoacidosis. Insulin therapy shifts phosphate intracellularly. Respiratory alkalosis. Hyperventilation increases intracellular glycolysis, causing phosphate uptake by cells. Other causes include hungry bone syndrome, acute leukemia treatment, and catecholamine infusion. The hallmark problem is ATP depletion, affecting multiple organ systems. Neuromuscular manifestations are muscle weakness, difficulty weaning from ventilator, respiratory muscle dysfunction, paresthesia, tremors, seizures, confusion, and coma. Cardiovascular. Reduced myocardial contractility, arrhythmias, heart failure, and hypotension. Hematological. Low ATP causes hemolysis, platelet dysfunction, and leukocyte dysfunction. This increases bleeding risk and susceptibility to infection. Musculoskeletal, rhabdomyolysis, osteomalacia, bone pain, and fractures in chronic disease. Diagnosis starts with confirming serum phosphate. Then determine the underlying mechanism. Evaluate calcium, magnesium, potassium, vitamin D, pH, and renal function. If renal phosphate wasting is suspected, calculate fractional excretion of phosphate and tubular maximum phosphate reabsorption. Review medications carefully. Always assess for alcohol use, malnutrition, recent insulin therapy, refeeding syndrome, hyperventilation, and chronic diarrhea. Treatment depends on severity and symptoms. Mild hypophosphatemia. Oral phosphate replacement is usually adequate. Examples include sodium phosphate or potassium phosphate preparations. Severe hypophosphatemia. If phosphate is below 1 mg per dl, or the patient is symptomatic, intravenous phosphate is preferred. Generally, 0.08 to 0.16 mol per kg intravenous for moderate deficiency and up to 0.32 to 0.64 mol per kg for severe deficiency, depending on institutional protocols and renal function. Potassium phosphate if potassium is also low. Sodium phosphate if potassium is normal or elevated. Monitor closely for hypocalcemia, hyperphosphatemia, metastatic calcium phosphate precipitation, acute kidney injury, and arrhythmias. Always correct hypomagnesemia, if present, because concurrent electrolyte abnormalities often coexist. Here are 5 important take-home messages. Number 1. Always check phosphate in critically ill patients, especially those with sepsis, DKA, alcoholism, or malnutrition. Number 2. Think of hypophosphatemia in patients with unexplained ventilator weaning failure. Number 3. Refeeding syndrome can cause rapid, profound phosphate depletion and should be anticipated before nutritional therapy. Number 4. Serum phosphate represents only a tiny fraction of total body phosphate and may underestimate overall depletion. Number 5. Treat the underlying cause, not just the laboratory value. Hypophosphatemia is a potentially reversible cause of respiratory failure, cardiac dysfunction, muscle weakness, and neurological deterioration. Early recognition, identification of the underlying mechanism, and appropriate phosphate replacement can significantly improve patient outcomes. If you found this video useful, please like, subscribe, and share it with your colleagues. Thank you for watching, and I'll see you in the next Critical Care Essentials video.